Good morning to you all. Honorable Emeritus Chairperson, Sir, Dr. M.L. Swarnakarji, Honorable Vice Chancellor, Sir, respected Pro VC, Sir, Director Medical Oncology, Medical Director, Sir, respected Dr. Sachdeva, Sir, and respected audience, my colleagues, my dear students. Today's CCR will be presented by Department of Nuclear Medicine. Nuclear medicine is a science which deals with the study of radionuclide, radiopharmaceuticals, and other radiotracers for the diagnosis, treatment, and purpose of research. Before start, I would like to pay my respect to Madame Curie, who invented the radioactivity in 1995 and received she is the only woman, she is the only person who received 2 Nobel Puriskar, one in polonium research and second one is invention of radium. And all these radioactive materials and radioactivity is used for the treatment of cancer and diagnosis both, and radiology also. The departmental journey start from 2019, February 2019, we installed first dual head gamma camera and PET-CT and started the MD nuclear medicine 3 years courses, post-graduation courses in the department in 2021. In addition to high dose therapy unit started October 2022, in which we are treating the thyroid cancer patient admitting for high dose iodine 131 and other high dose radiopharmaceutical for observation, and then we discharge. And MSc Nuclear Medicine, which is very important subject for the nuclear medicine, and we are giving the degree, post-graduation degree to the technologists, nuclear medicine technologists who work in the department, and without nuclear medicine technologists, we cannot receive the authorization and permission and license from the AERB, BARC. So we have started 15 candidate of MSc per year admission every year. At present we have 15 candidates. Then in addition to second PET-CT, it was also inaugurated in April 2024 in presence of Honorable Chairperson, Emeritus Chairperson Shri Swarnakarji and Honorable Chief Minister of Rajasthan. Then we have installed the germanium gallium generator, by which we are manufacturing the radionuclide, radiopharmaceutical like PMSA and DOTA for the diagnosis purposes of neuroendocrine tumors and prostate cancer. This slide showing available facilities of gamma camera and PET-CT. First one is in SRCC building, gamma camera and PET-CT, and second PET-CT was installed in this one is the PET-CT. The second one along with the high dose ward. We have 4 high dose ward, so there is no deficiency for the any treatment and all. And we have also we are also manufacturing the gallium in house and technetium also for general purposes of nuclear medicine studies. This slide showing the molybdenum technetium generator, and second one is gallium generator. And we have in the department 3 faculty, Dr. Karan Pipre, myself, Professor and Head, Dr. Tarun Jain, He is Associate Professor in Nuclear Medicine. Dr. Ram Singh Meena, Assistant Professor in Nuclear Medicine. A very good team, very energetic, very dynamic, and reporting more than 35 patients of cancer patient, performing PET CT, different type of the various type of the cancer, different type of the studies, and PET CT guided biopsy also, FNAC and biopsy, which is very rare in the country. These are the postgraduate students. We have 8 postgraduate out of 8 to pass and joined in other center also. And second batch will be appear after 3 or 4 months, Dr. Dadhich and me, and then 4 students we are teaching to this nuclear medicine. These are the services available in the department. All world-class international standard services we are giving to the patient of the Rajasthan and other states. And the most common is very frequently and daily giving this service is PET CT, FDG PET CT for the diagnosis of various malignant lesions and response evaluation also. Second one is 99 technetium labeled radiopharmaceutical DTPA, DMSA, thyroid imaging, renal imaging, hepatobiliary, and also we are treating the patient of various type like follicular carcinoma of the thyroid and liver cancer also, yttrium 90 thromboembolization, which we have done more than 8 or 10 patients in our institute. And this is very excellent therapeutic material, rhenium, and 177 lutetium PSMA therapy to the patient of chemotherapy and immunotherapy resistant cases of prostate cancer, which is very rare in other center also. We are the most commonly using this technology here. This is departmental statistics from 2019 till date. We have performed, investigated 21,000 of PET CT, which is a very big figure, and presented papers and posters and received prizes also. I have received first prize in a medical oncology conference at Bhubaneswar. Dr. Honorable Malhotra Saab has given prize to me on PET CT breast cancer. And other papers also presented by Dr. Tarun and Dr. Meet, PG student. And we are also performing the high dose iodine 131, DOTA-TET, lutetium, PSMA, and bone pain palliation also. All type of the bone pain palliation we are giving, like samarium and rubidium, samarium and lutetium. This graph shows PET CT gradually increasing. Number of PET CT investigation is gradually increasing day by day, and gamma scan also is increasing. High dose patient also we are admitting and giving the radioactive iodine and other radionuclide material, and patients are increasing. This is departmental statistics. We have till date we have performed 21,000 and more patients. This slide showing second PET CT inauguration by Honorable Chief Minister and Honorable Emeritus Chairperson, sir, and other ministers of Rajasthan. And we are performing in second PET CT more than 15 patients per day, and it's a great achievement for the Department of Nuclear Medicine, MGUMST. This we have received first prize, Best Center Excellent Award in Rajasthan by IMA. These are the conference organized here. We have Department of Nuclear Medicine organized 4 conferences, national conferences in our institute on nuclear cardiology and high dose therapy, and publication of the department. Many papers and posters are published, research papers are published in the literatures. And today's combined clinical round is on 30 years old female with refractory epilepsy. The CCR is presented by Department of Nuclear Medicine. Now I will invite to Dr. Pavni Agrawal, second year DM resident, to start the case presentation. Thank you very much. Thank you very much, sir.
Good morning to all. I am Dr. Pavni Agrawal from the Department of Neurology, and I am going to present the case of a 30-year-old right-handed female resident of Bikaner who presented to us with history of seizures for the past 8 years. Her seizures started at the age of 22 years, and initially the frequency was 1 episode per day, and she attained seizure freedom for the next 3 to 4 years after starting her on appropriate anti-seizure medications. But unfortunately, she developed recurrence of seizures despite being on treatment. There are two types of semiology of her seizures, one of which is described in the video, where we can see that she has deviation of head and eye to the right side with some focal movement of the right upper limb along with ictal cry. This case is particularly close to my heart, as she is a mother of 2 young children and a homemaker. And these intractable seizures have a profound impact on her daily life. During one such event, accidentally she dropped her young son, who had a head injury. During another such episode, she burnt herself. Unfortunately, she has to go through such horrendous activities or horrendous events on a daily basis because of her intractable seizures. So then, we took her past medical history, and the pertinent past medical history was insignificant. We then took a detailed drug history, and her anti-seizure medications kept on increasing over the years. So according to the ILE definition of drug-resistant epilepsy, it is the failure of adequate trials of 2 well-tolerated and appropriately chosen anti-seizure medications to attain sustained seizure freedom. Beyond this point, the addition or likelihood of achieving seizure control with the addition of the next 3rd, 4th or 5th drug goes to less than 5%. So despite her being a case of drug-resistant epilepsy, her anti-seizure medications were added simultaneously over a span of many years.
Drug history of our institution or different institution?
No sir, outside. On general examination, her vitals were normal and she had no deformity or any neurocutaneous markers.
So Pavni, can I ask a question? When you say that at least 2 anti-epileptics are not working and the seizures are persisting,
Yes,
to label it as refractory seizures,
yes.
do you have to document adequate blood levels or that is not mandatory?
Yes sir, we should document the adequate blood levels ideally.
Because all of the most of the drugs have first pass metabolism and each person would absorb the drug differently, right?
Yes sir.
That was my intention to ask, are we doing the blood levels in our central lab for these
Yes.
anti-seizure medications?
Yes sir, yes sir.
Which medications we are doing
Sir,
anti-seizure?
in our in-house we have levels available for phenytoin, valproate, sodium valproate, carbamazepine, oxcarbamazepine, levetiracetam, all the major anti-seizure medications which we are using.
And why have you mentioned right-handed specifically for this patient?
Sir,
Any reason for that?
Yes sir, because usually when we take neurological history, it is important for us to know the dominance of the hemisphere, because the major control of the language center is usually from the contralateral hemisphere.
Can I give one small advice?
Yes sir.
Bachi, when we are presenting, this is for all the postgraduates, when we are presenting a history, adjectives need to be left out. Horrendous, close to my heart. These are a part of a general conversation, not as a part of a scientific history presentation. Okay?
I'm sorry sir. Should I? To move forward, on doing a detailed neurological examination, we found that her higher mental functions, cranial nerve examination, the motor examination, sensory examination and cerebral examination was normal, and she had no meningeal signs. A brief cardiovascular, respiratory and abdominal examination was also done, and it showed no abnormality. So to summarize, we have a case of a 30-year-old female with drug-refractory epilepsy and a normal systemic examination. To move forward in our case and to confirm and establish the semiology of these events, a 24-hour neurotelemetry or a video EEG was done. As per International League Against Epilepsy, seizure semiology refers to the study and classification of the clinical manifestation of seizures. It emphasizes the observable signs and subjective symptoms during a seizure, which are then interpreted to help to localize the seizure onset and the spread of the ictal activity through the brain networks. This is a video EEG which is used to see the congruence of the clinical symptoms with the electrical activity in the brain. In this video record, in the inset, we see the clinical symptoms with a simultaneous EEG recording. This is a 20 electrode bipolar montage with the right leads depicted in red and the left depicted in blue. This helps to localize the epileptiform discharges in a case of a seizure. This is a video recording, and in our case, we could localize the onset of seizure from the left temporal region, which is depicted in blue, and the leads are T3, T5, T7. So, the main cause of drug-resistant epilepsy with focal onset can be broadly classified into infective and non-infective causes, with structural cause being the most common one. To rule out further metabolic and infective cause, we did lab investigations which grossly came out to be normal. With this, we could rule out infective and metabolic causes. But we had a high suspicion of a structural lesion since it is a case of focal epilepsy in the temporal lobe. For this, we requested a MRI brain with harness protocol, but it was reported as normal. So this was the unique challenge in our case. The patient had consulted multiple doctors over years in Delhi, Jaipur, Ahmedabad, but since no structural lesion was detected on MRI, there was a lag in reaching to an accurate diagnosis and appropriate management. Clinically, patient has focal epilepsy, although MRI brain is reported as being negative. So we requested the nuclear medicine department to help us move forward in the case, and we requested for a FDG brain PET scan. Thank you. Now I would like to call Dr. Shubham to take us forward with this case.
How frequently you ask for an FDG PET in a patient with epilepsy? Suppose you see 100 patients, how many you would ask for an FDG PET?
Sir, it's a systemic process. Firstly, we need to localize whether the seizures are focal onset or generalized onset.
How frequently you ask for an FDG PET in patients with epilepsy?
Almost all the patients with a focal epilepsy, as a part of pre-surgical evaluation, we ask for FDG PET scan.
How many patients with epilepsy go for surgery?
Sir, the chances of refractory epilepsy is close to 30%. So if you see 100 patients with focal epilepsy, 30% will be refractory. But because of all the dilemma to surgeries and everything and awareness, we are not doing so much. So far we have done 62 cases, discussed surgical cases, and 33 has underwent epilepsy surgery in the last 1 year.
What is the denominator? Total number of patients with epilepsy, total number of patients with focal epilepsy, then how many had a lesion and how many went for surgery, and out of that, so my purpose of asking this is, how do you decide that this patient should have an FDG PET? It is not done in every case.
It is not done in every case, but when we are doing a pre-surgical department, we would check. So specifically in those subset of patients, we definitely take help of PET CTs and even SPECT. The reason is that epilepsy is a dynamic thing. It is not something which is static. So PET always help us in making a concordance and going ahead with the surgical option. But asking that out of say 100 patients with epilepsy, how many usually need PET? Hardly 2 to 5%, not beyond that.
Good morning, all the respected dignitaries, faculty members, and my dear colleagues. I am Dr. Shubham Dadhich from Department of Nuclear Medicine.
I think जब तक आपका load होता है, Shubham, I can ask you a question. When we ask for PET scans for in an oncology setting, there is always the disclaimer which the nuclear medicine department puts, that visualization of brain lesions is not very good with PET, and think of other investigations. And here you are asking for a PET scan of the brain. So will you clarify in your presentation?
Sir, yes. In brain we have high physiological uptake of FDG, which I'll discuss further. But epilepsy foci will be a hypometabolic foci, and we need to find out between the rest of the physiological uptake.
FDG in brain?
Sir, because FDG is same as glucose, and our brain works on glucose. So it's approximately 12% of glucose and 6% of FDG is taken up by the brain parenchyma.
Full form of FDG?
It's fluorodeoxyglucose, sir.
Basically it is a radioactive.
It's a radioactive glucose. Oxygen at 6th position is replaced by 18 fluorine. So it's same as glucose. So a 30-year-old female with refractory epilepsy and no significant examination findings and no significant finding on lab investigation, but the focal seizure on onset and semiology and video EEG was sent to the Department of Nuclear Medicine, but the problem here was the MRI, which was done in harness protocol and showed no significant abnormality.
You could have gone for functional MR because it is focal epilepsy involving one zone, where you could have gone for seeing the vascular supply of that particular area.
Sir, when we go through the data.
Are we doing functional MRI or not?
Sir, I am from Department of Nuclear Medicine, not from radiology.
Doesn't matter. आपस में बात तो करते होंगे यार, ऐसे क्या? Don't live in compartment. कल ही तो अपने JCI का approval मिलने की chance है.
Sir, we are.
Okay, let the radiology people answer.
Currently we are not doing.
What is the problem?
So the requirement is not so much like the.
The requirement is there.
Sir, in this particular case, patient or for example any drug refractory epilepsy patient, functional MRI can just help us in deciding the
location,
the eloquent areas of the brain. For example, whether language is sitting there, whether the focal cortex, the motor cortex is sitting there or not. But when talking about the structural pathology, functional MRI doesn't help us in localizing the.
I think it is very important. As far as surgery is concerned,
definitely yes.
You may like to avoid the language area.
Definitely.
You may go for the memory.
So gone are the days when WADA test. Earlier WADA testing was done to localize language, but since the time of fMRI, which has come up, all those invasive testing have completely become obsolete. So whether we need an fMRI or not, definitely yes. It costs a lot, and we are working upon it, sir.
You let us know the.
Yes,
cost.
yes, sure.
So to dive into the basics of epilepsy from the perspective of nuclear medicine, to understand epilepsy we divide it into two phases, that is ictal phase and interictal phase. In ictal phase there is high discharge from the epileptogenic foci, which in turn causes high blood flow at the epileptogenic foci and therefore increases the metabolism. In interictal phase there is low or no discharge from the epileptogenic foci, which causes normal or decreased regional blood flow, but always causes decreased focal metabolism. To assess the metabolism,
for the sake of other residents, can you tell me the difference between epilepsy and seizures?
Sir, 2 or more unprovoked seizures is epilepsy. Seizure is a part of epilepsy.
What is seizure?
Sir, seizure is uncontrolled body movements which has onset, which is provoked from the brain parenchyma.
So what is the electrical activity in the brain? How will you scientifically say like that?
Sir, when there is some functional defect, or we can say there is.
You have to say abnormal electrical movement.
Abnormal electrical movement leading to abnormal body movements.
Only movements?
Sir.
How many types of the seizures are there?
Sir, there are 2 types of seizure: focal seizure and generalized seizure.
From the function point of view. जैसे मोटर बोला ना आपने, दूसरे कौन से हो सकते हैं?
Sensory seizures.
Smell जा सकती है, vision जा सकता है, hearing जा सकती है, taste जा सकता है. तीसरे कौन से हो सकते हैं? अभी लास्ट वीक ही थी एपिलेप्सी पे UGCR.
Absent seizures हो सकते हैं सर.
Absent seizure. What is the difference in hysteria and absent seizures?
Sir, a person with absent seizure will not be knowing that I had an absent seizure, but person with hysteria will be knowing that I had a seizure. So generally the history will be given for the absence seizure, history will be given by the attendant, but if the person is having hysteria, history can be given by the same patient.
You know the origin of the word hysteria?
Yes, sir. It's from...
Make gynecologist as a friend.
Yes, sir. Hysterectomy, yes, sir.
Hysteroscopy.
Hysteria is generally seen in pre-married women.
Where does it come from?
Sir, it comes from uterus.
Yes, so basically in 18th or 19th century, they thought it is the wandering uterus, which is responsible for this uncontrolled movement or sort of syncope or seizures. So they gave, but it ultimately is not. Now, what is the new terminology given for the word hysteria in neurology? No.
Terms like hysteria, psychogenic non-epileptic, psychiatric seizures, they have to be done away with. That is why the newest recommendation is we use the term functional movement disorder. It can be both hyper or hypo. Sometimes patients just present to us with weakness, and it's just a functional element. So functional movement disorder.
There will not be any EEG changes in hysteria. Remember that.
Yes, sir. To assess the metabolism, we use 18F FDG brain PET imaging, and to assess the regional blood flow, we do the SPECT brain perfusion imaging. As interictal procedures are more convenient and they are part of basic protocol of epilepsy, drug refractory epilepsy of focal onset, we did a 18F FDG brain PET scan. After injecting 5 millicurie of 18F FDG via intravenous route, we made the patient rest in a dark room for approximately 45 minutes with eyes closed, and then a dedicated brain PET images were required for 10 minutes, which were fused with the CT images. FDG is nothing but fluorodeoxyglucose, works same as glucose, which acts as a fuel for brain parenchyma, and approximately 6% of the injected dose is taken up by the brain parenchyma, which makes it it's a most sensitive investigation to look for epileptic focus in interictal phase. So and reduced metabolism, as I've already told that there is reduced metabolism in epileptogenic foci is due to neuronal loss, diaschisis, and reduction in synaptic density. After 45 minutes, we acquired brain PET, and we found that when compared with normal PET, in which in orange we depict the normal high physiological uptake of brain parenchyma, and in green there is relatively lower uptake in white matter, and in red depicts the gray matter. We can compare it with the scale in the middle. Red is higher uptake and green is lower uptake. When we compared the normal brain PET with the patient's PET, we found that there is relatively decreased uptake in left mesial temporal lobe, which was also evident on the coronal images of brain PET. When we studied the whole brain parenchyma, we found that there are other areas of hypometabolism in bilateral parietal lobes, right frontal lobes. So we tried to make a diagnosis with whatever we had. So we took the DICOM data from MRI and co-registered it with FDG brain PET, or we can say superimposed it on FDG brain PET. Thank you management for the state-of-art facilities where we can co-register or superimpose both these diagnoses. But even after co-registering these brain PET with MRI, we have not found any significant abnormality in left mesial temporal lobe as well as bilateral parietal cortices. So our summary was focal areas of hypometabolism in left mesial temporal lobe, right frontal lobe, and bilateral parietal cortices with no significant morphological abnormality. Since we have even after fusing with co-registering PET with MRI, we are not able to find what is the true epileptogenic foci. So we tried to we decided to go ahead with the ictal SPECT to increase the chances of finding epileptogenic
for the
foci.
audience, I would like to ask two questions here from you. First question is very basic. How much time do you usually take to read a oncology scan, PET scan? And how much time do you devote to read a epilepsy brain scan?
Sir, I mean, for a normal oncology scan, it differs from person to person. For example, we take approximately one and a half hour.
Correct. My point of asking
sir
is
takes 10 minutes, 20 minutes.
But in epilepsy, how much time?
But in epilepsy, it takes approximately 3 to 4 hours. We first take the DICOM data from patient. We import it from Department of Radiology. Then we co-register it with MRI. Then we try to see the abnormalities in both PET-CT as well as on the MRI.
And the main reason is that when you talk about oncology,
we also relate it with the clinical semiology on video EEG and
so oncology, everything is hypermetabolic. It stands out and comes into your eyes. But when you're looking for hypometabolism, you have to devote a lot of time searching for it. The second question here is that you have focal areas of hypometabolism at 1, 2 and 3 sites. We are giving you the data that okay, we have this suspicious area, but how do you explain the other hypometabolisms?
Sir, the other hypometabolisms, there are various reasons for other hypometabolic areas. One of which is that when the epilepsy, I'll be coming to it in the further slides, but when it starts from a focus seizure, but when the epilepsy gets generalizes, the other areas, other neurons which are discharging in the interictal phase, they are hypometabolic too. So if the fire is in the entire jungle, we don't know from where the exact point of spark was, and other causes can be due to some drugs, for example clobazam and gabapentin which was given. Studies have shown that these causes generalized reduced metabolism in other areas. Thank you, sir.
Just a quick question to supplement that. Why exactly are in the interictal phase, why exactly are the seizures focused hypometabolic and not normometabolic? What is the reason for that?
Sir, I told in the basics that I mean, if you are talking about particularly brain PET-CT, in the interictal phase, there is already the neuronal loss. Patient is suffering from epilepsy from last 8 years, and there is diaschisis. There is reduction in synaptic density, due to which there is reduced FDG uptake. Even in further stages, these are the initial stages. In further stages, we will able to see even the volumetric loss in MRI. But these are the initial stages where we can see the reduction in FDG uptake.
I always tell my residents this teaching that when you're doing a PET scan interictal phase, the epileptic focus is hungry, but the doors are shut. So the whole brain will take up the glucose, but the epileptic zone will not. But when you talk about SPECT, where the seizure is going to happen, that door is open. Now the maximum food is going to be taken up by the person who is the most hungry. So the whole picture will change when you discuss SPECT.
So we are, even after co-registering PET with MR, we are not able to find the true epileptogenic foci. So we decided to go for ictal SPECT, which is to increase the chances of finding a true epileptogenic foci. What is ictal SPECT? It is a brain perfusion study done with gamma camera using technetium-99m ECD, ethyl cystinate dimer, and it is a most sensitive scan to look for epileptogenic foci overall.
Just go to back slide. Why it is known as gamma camera?
Sir, because technetium-99m is a molecule which converted into technetium and emits gamma rays. So we scan gamma rays on this, and therefore it is named as gamma camera.
What we have, double head or single head?
The dual head gamma camera. We have dual head discovery gamma camera.
But we are not having SPECT.
Yeah, we have not having it with CT.
So gamma rays are produced from the tracer.
Yes, sir. Gamma rays are produced from the tracer. For attenuation correction and for localizing the exact point of emission of gamma ray, we need a CT, but we roughly do it due to absence of CT.
Like you imported MRI film, you can import the CT?
Yes, we generally do it. We now do it. We have CT in PET machine, So we take CT from that, and we take SPECT on gamma or SPECT images on gamma
so
camera.
what can be the advantage if we have SPECT CT?
Sir, fusion is very different from superimposition or co-registration. In fusion we take two images, merge it by pixel to pixel, and a new image is created, like in PET CT. The machine is having PET and CT. We go for fusion, but in superimpose we just
CT का function क्या है? CT क्या reveal करता है आपको?
Sir, exact location of.
Location mean structure.
Yes, sir.
और गामा कैमरा क्या, गामा रेज क्या रिवील करती हैं आपको?
Sir, physiology.
So if you have the structural location as well as the physiology, then you will have better
resolution, better.
So be very clear. SPECT is only for the physiology. SPECT with CT will reveal the structural as well as physiological changes, which will further aid to the diagnosis. So for the general audience, you have to be very, very specific. CT for the structural, SPECT for the, or SPECT to double head gamma camera or triple head or whatever you want to say, is for the physiology. Chalo.
We can use the CT here in our machine also. We can update the.
तो सर आप डिमांड तो रखो, जब आपको सेकंड पैट CT ला सकते हैं, तो ये भी ला सकते हैं. When we are showing 300, 400 cases,
yes sir,
done in a year, then why not to have?
I will send.
So like a spark converts into fire and engulfs the entire jungle, focal scissor lateralizes to convert into generalized scissor and is spread over the entire brain parenchyma. So to avoid the fire, we need to look for the spark and remove it as soon as possible, and for this we inject the tracer as soon as possible. To highlight the complexity of the procedure, I would like that this is not a routinely done procedure. This we do only in patient where we have not found anything on MRI as well as on PET. We elute technetium in our department. From technetium generator, we mix it with component A and B, and then make in-house we make technetium 99M ECD with proper precautions.
Control for all this?
Yes, sir. Yes, sir.
You ensure that everything is fine?
Yeah, is fine. Under proper precautions. Ethyl cystinate dimer. Sir, this is loaded in a syringe. This syringe is kept in a syringe carrier, which is further packed in lead and tungsten carriers and transported to the Department of Neurology in a video EEG room under proper radiation safety precautions, and where we wait for the seizure onset. If there is seizure onset, we inject the tracer as soon as possible. But if there is no seizure onset, we wait for 6 to 8 hours and the dose expires. Dose expires within 6 to 8 hours, and the next dose is prepared beforehand and sent to the Department of Neurology. This ECD injected.
So one like a silly question: the person who is injecting, does he have to wear lead gloves and stuff? Yeah.
Yes, not lead gloves, normal gloves, which are discarded after with TLD material. Monitor the radiation. Proper radiation safety precautions are taken, sir. This ECD, once injected into the blood, is a lipophilic compound, readily crosses blood-brain barrier, accumulates inside the brain, and converts into ECM, ethyl cystinate monomer, which is a hydrophilic compound, and accumulates in the brain parenchyma according to the perfusion. Where there is high perfusion, there is increased accumulation of ECM and increased radiotracer uptake. But before taking to the patient, we manage the epilepsy first. The epilepsy is first managed by our neurology team, and then the patient is taken for SPECT scan. When we compared the interictal brain PET in this particular patient, when we compared the interictal PET CT scans with ictal SPECT, which was done in this patient, the focal hypometabolic areas which were evident on interictal PET CT showed no tracer uptake in bilateral parietal cortices. As we can see, the other hypometabolic area on right frontal cortex also showed no focal tracer accumulation in ictal SPECT. But the right mesial temporal lobe area, which was hypometabolic on interictal brain PET CT, showed increased tracer accumulation in ictal SPECT, which was also evident on these axial, coronal and sagittal images. So we concluded that there is a differential focal tracer accumulation in left mesial temporal lobe, which is likely the epileptogenic foci, and this case was taken to the multidisciplinary epilepsy board, which is headed by Dr. B.S. Sharma sir, and has Department of Neurology, Department of Pediatric Division of Neurology, Department of Neurosurgery, Department of Radiology, Department of Nuclear Medicine, Department of Pathology, and the decision of surgery was taken. So to discuss about the surgery, I would like to call Dr. Anmol Randhawa sir from Department of Neurosurgery to further take up the case.
Thank you, Dr. Shubham. Good morning, respected teachers and my colleagues. So when this case was discussed in the epilepsy board meet, it was decided that surgery is the best option of management for this patient. When we talk about epilepsy surgery, we broadly classify it into two types, that is palliative surgeries and curative surgeries. Curative surgeries are the ones which are considered the treatment of choice, since palliative surgeries, they decrease the frequency of the seizures, but they do not completely eliminate the epilepticogenic focus. But curative surgeries, they help to completely eliminate the epilepticogenic focus. And the primary goal of curative surgery is that the patient can live a normal life, preferably of all anti-epileptic medications, and that the patient can become seizure-free at a younger age, which can in turn lead to better quality of life. And when we talk about curative surgeries, the gold standard in curative surgeries is standard temporal lobectomies. And temporal lobectomies, they consist of resection of the anterior temporal neocortex along with the medial temporal structures, including amygdala, hippocampus, fusiform gyrus, parahippocampus gyrus, uncus. And in literature, the extent of resection in the left side or the dominant side is 3 to 4 centimeter, and the extent of resection on the right side is considered 5 to 6 centimeter. Now what was unique in our case was that there was no lesion that was present, no structural abnormality was present in our case. So intraoperatively it was difficult for us to define the margins of resection. So in consultation with Department of Neurology, we decided to use intraoperative electrocorticography so that we can define the margins of resection better. So we made a curvilinear question mark shaped incision on the left side, and after raising the myocutaneous flap, the dural flap was raised and a strip of 6 electrodes was used for electrocorticography. This strip is placed on the superior, middle and temporal gyrus of the left temporal lobe. Now interestingly, in our case, the abnormal electroform activity, it was coming below, posterior to the standard 3 to 4 centimeter margin, which is standard resection margin. So again we had a decision to make. Should we go for aggressive resection and risk Wernicke's aphasia? Because Wernicke's area, it is present posterior to the left temporal lobe, or we can go for safe standard resection and risk leaving the epilepticogenic focus behind. So it was decided to go for standard temporal lobectomy along with multiple subpial transections posteriorly. So subpial transections, in that we disturb the horizontal epilepticogenic circuits, but we preserve the vertical circuits of the brain. So the normal cortical function, it is preserved. So in surgery, we first mark the cortex that is to be resected with the help of electrocorticography with bipolar. Now this is a picture of the illustrating the temporal lobe anatomy, which highlights the superior, middle and inferior temporal gyruses. First, we proceed with lateral neocortical dissection, and after visualizing the middle temporal fossa floor, we proceed with subpial medial temporal cortex dissection, which is then followed by removal of the medial temporal structures, such as the uncus is removed. This is followed by visualizing the hippocampal area, and the hippocampus is removed, followed by removal of the parahippocampal gyrus. It is the most important during surgery is to stay subpial to avoid injuring the structures which are medial to the pia. After removal of the parahippocampal gyrus, we can visualize the oculomotor nerve and the posterior cerebral artery and the posterior communicating artery is visualized medial to the oculomotor nerve. Then after the end of the surgery, we again use electrocorticography strips to delineate the margins and to confirm adequate resection. And in our case, after using the electrocorticography strips post-operatively, we confirmed that there was no abnormal epileptiform activity present. The specimen was removed and sent to histopathology for further diagnosis. The surgery was uneventful. The patient was extubated immediately post-operatively with no new neurological deficit. NCCT head was done post-operatively, which was unremarkable, and the patient was discharged on day 3 on the same anti-epileptic drugs. The patient was followed up on post-op day 12 for suture removal, and he had no new seizure episodes on the same anti-epileptic medications.
How long you will use anti-epileptic drugs after the surgery?
So generally the protocol is to continue the same anti-epileptic drugs for 1 to 3 months. The patient is followed up in neurology and they gradually taper the drugs after the first month. But for the first month they continue with the same anti-epileptic drugs.
You said there is a standard surgical procedure for epilepsy which you described.
Yes, sir.
So if it is so, then why do we need all this localization?
Sir, the reason we needed this localization was because firstly, before the diagnosis, we could not localize the lesion to the medial temporal lobe.
But you said the procedure is standard.
Sir, standard for medial temporal lobe epilepsy. Temporal lobectomy, sir.
So that will be done in every case irrespective of where
Sir, it will be done only in cases where the focus is localized to the temporal lobe or the medial temporal lobe to be specific.
Standard temporal lobectomy defines that these structures are to be removed.
The question is, in every patient who has a focus in the temporal lobe, these all areas will have to be removed.
Yes, the gold standard procedure for the patients who have focus in the temporal lobe, anterior temporal lobectomy is considered
not just the focus.
No, sir. Not sir.
It has been tried earlier in literature and earlier that only the amygdala or the hippocampus can be taken out, but the results of complete ATL-AH has been 85 to 98% seizure freedom, because epilepsy, when coming from mesial temporal lobe, they sometimes make a new recruit new neurons and they make a new navigational system. So the seizure freedom post-operative is maximum when you do a complete anterior temporal lobectomy with amygdalo-hippocampectomy.
Thank you, Dr. Randhawa. I am Dr. Anchal Bishnoi from the Department of Pathology. So we received the gross specimen measuring around 6 into 4 centimeters. On microscopy, in the first image, we can see the normal lamination of the cortical neurons which are aligned vertically. In the second image, there is a glial area which contains glial cells which have round to oval nuclei in the fibrillary background, and mitotic activity was not significant. So the differential diagnosis after HE was reactive gliosis and adult type diffuse glioma, astrocytoma, CNS WHO grade 2. So after IHC, IDH came out to be negative, P53 was negative, GFAP was also negative, and MIB was also negligible. So on NUN, the second image shows the areas of radial and tangential cortical dyslamination of neurons and some dysmorphic neurons. So the confirmatory diagnosis after both IHC and HE came out to be focal cortical dysplasia type 2A with areas of reactive gliosis. So I would like to call Dr. Tarun, sir.
Thank you, Dr. Archer. Good morning, respected dignitaries, seniors and dear students. Myself, Dr. Tarun Jain. I am Associate Professor in Department of Nuclear Medicine. I am concluding this case, and patient after the surgery comes on follow-up in Department of Neurology, and there is a significant decrease in the dose of the anti-epileptic medications. On a follow-up of 3 months, there is a patient is seizure free. after the surgery, and there are significant improvement in the social and work-life balance. So this is the reason why we select this case for the CCR, because this is a case of the younger age female. She is married and she has a seizure since last 8 or 9 years, and but these are not controlled since 2 years. This is called the refractory seizures and having the significant problems related to cognitive, behavioral and psychological problems. And when on workup, MR was negative, so we are not localizing the seizure focus, and patient came to our department. We did the ictal PET and it was also inconclusive, so we are not localizing the target focus, which are where from the epileptogenic foci are, which is the epileptogenic foci. So we integrated our ictal PET with the ictal SPECT and we make it decisive. This is a single epileptogenic focus in the medial temporal cortex on the left side. But challenges are not end up because due to lack of the anatomical landmarks, the neurosurgery department has a lot of challenges. So with the help of the ECOG, they have performed the very good surgery, and after the surgery, patient is the seizure free. And from our department data, we are the only center where we are performing the surgery for the refractory epilepsy in the Rajasthan, because we have a very good team which is headed by the Dr. V.S. Sharma sir, and we have very good neurologist Dr. Ajay sir and Dr. Valveen sir with us, and we have done the imaging workup in 38 patients, and out of 38 patients we have done the surgery at our site in 32 patients. And the outcome of surgery is too early to tell because the follow-up period is less than 1 year. So when we are reviewing the literature related to this case, and we found there is already published in various journals, and they also specify the PET and ictal SPECT is a very good imaging modality in decision making of the pre-surgical stratification. The MR negative term is coined in the epilepsy is in 2015, and its first publication came in 2017. They have taken the 26 cases and they found there are very good surgical outcomes when they have added the FDG PET finding in these type of the cases. So when we are reviewing the literature and we are concluding the sensitivity and specificity of the PET and SPECT, it's around 80 to 90%, and it is significantly increased in the temporal lobe epilepsy. So we are dealing with the neurology, but we are not only limited up to the seizure disorder. We are also helpful in various disorders like neurodegenerative disorders, dementia. We are helpful in the assessment of the penumbra and stroke. We are helpful in tumor and paraneoplastic syndrome, brain death identification, myositis and neuropathy. We are using the special type of the radio tracer called the F18F DOPA for the differentiation of the Parkinson and non-Parkinson disorders. We are using the brain technetium level radiopharmaceutical for different purposes like brain perfusion study in the detection of the moya diseases, and CSF flow assessment to detection of the CSF leak study. So I am concluding this CCR with few take-home messages. And this is not a single man job. This is a team job, and with the team effort, we reach up to the diagnosis and treated the patient. We played a crucial role in the diagnosis of this epileptogenic foci. We are not only giving the diagnosis in MR negative, we are also giving the diagnosis in MR positive findings also. And we are the center only, we are performing the epilepsy surgery in the Rajasthan, but there are lack of awareness even in society and clinicians that epilepsy can be managed by the surgery. So it's our duty to and make a programs to prepare and spread the awareness about the epilepsy surgery. And I want to tell you one thing, the nuclear medicine is not limited up to the oncology. It's also, we are also dealing with the cardiology, neurology, endocrinology, rheumatology, gastroenterology. So many fields. So, So whenever you stuck at the time of the workup of the patient, when you feel there is no path, you can discuss the case. We are not only giving the diagnosis, we are doing the intervention, so we can help you in making a diagnosis of the patient. So at the end, I want to give the thanks to management of MGUMST who gave us a chance to present a case. And I want to give the thanks to patient and family, and I want to give the thanks of the Neurosurgery department who gave us who done the very good surgery for the patient.
Sir, I'll request the audience to stay on because there is another presentation after this.
So I think before we kind of dilute the thunder of this presentation, my personal opinion is that this was an incredible case and incredibly worked up, and I dare say that there would be just a few centers in the whole country who would be able to do this. So like big round of applause to the whole team.
In fact, we are lucky to have a patronage of Dr. B.S. Sharma, who is a legendary neurosurgeon, and Dr. Balveer and Dr. Ajay Goenka, good radiology and nuclear medicine team.
A very good morning to all the respected faculties over here. In view of the recent incidents happening across the Rajasthan and in our city also, this small presentation in terms of sensitizations and interaction, this seminar, this CCR has been planned by Medical Superintendent and Director Dr. S.S. Jaiswal sir on safe transfusion practices. So as we all read the newspapers and we have gone through these news in the newspapers that B positive, patient was B positive but blood given was A positive. What resulted? Harm to the patient. Another patient, 10 years old boy, admitted for anemia, but again the wrong blood group was given, resulted in harm to the patient. Kidney patient, 10-year-old boy, given wrong blood group, resulted in death of the patient. Mom to be 23 years old female, given wrong blood. What resulted? Again, the death of the patient. So why all these things are happening? Just because of the negligence. Recently, in view of all these things happening in Rajasthan, the government officials called up a meeting and our blood center was blessed enough to be part of that committee and to frame the guidelines for the Rajasthan that what should be done when the patient gets admitted. But our blood center, it's already NABL and AABB certified, so we are already following those guidelines, and our guidelines became the landmark for other government officials to frame in their institutes. So, but today, through this platform, I really want to share the challenges which we are facing. Although everything is at their place, all the SOPs and policies are there, but still we are facing the challenges. Sample with wrong IP number and the details. Again, sample with wrong UMR number and the patient details. Patient is reactive for the hepatitis, but there is no biohazard label pasted on the requisition form. Again, the sample with the wrong details. These are the examples which I am just sharing today. So I want to highlight one case. Recently, last week, we received a sample for the blood grouping on 29th of the May, which was reported as O positive, and another sample received on 31st of the May was reported as A positive. The details on the samples, including the name of the patient, the IP number, the age, the gender, everything was same. This is sample 1 with all the details. But when the reporting was done, we rechecked. One of our staff during the audit found that the reportings were different. One was O positive, another was A positive. We took the corrective action. We went to the ward where the patient was admitted, and what we found, can anyone assume what we found? 2 samples were in the tubes. One was of the mother, another sample was of a newborn baby. So one was O positive, another was A positive. So we invoked the reports from the software, we recollected the samples of both the patients, and we reported it again. As I said that Mahatma Gandhi Blood Center is NABH as well as AABB certified. So as per the policies, we have to report all the incidences, whatever is happening, and we do take the corrective actions in form of giving the training to the staff. But recently what we observed that most of the errors are occurring because of writing through the pen on the forms. So just to overcome that problem, we have started giving a new software named as bot software. In that we can get the online request and no transcription error or any error related to the overwriting will be there. So I request everyone sitting over here that please start using that software so we will not encounter such problems in the future. Why such incidents generally happen? It mainly happens because of the wrong blood in the tube. Blood is taken from the wrong patient and is labeled with the intended patient details, or blood is taken from the intended patient but labeled with the wrong patient details, and mostly it do happens. Recently a survey was done by the Hemovigilance in 2023 and 2024 on 986 patients, and they concluded that 44% of the patients were not identified during the collection of the samples, 29% of the patients were not labeled properly after collecting the samples, and 7% of the samples were not labeled by the person who is taking the sample. What happens in the ward that the nurses are taking the samples, they are bringing the sample back to the nursing station and someone else is labeling the sample. This is also resulting in harm to the patients. So just to sensitize everyone sitting over here again, that the good transfusion practices always ensure that the right blood should be given to the right patient and at the right time. This is our policy, that at the time of the admission of each and every patient who is suspected to get the transfusion during their stay in the hospital, there should be a 2-sample policy. 1 sample at the time of admission of the patient, that is for the blood grouping and the antibody screening, and the 2nd sample when we get the request for the transfusion, again for the blood grouping and for the antibody screening. So these 2 identifications, 2-time reporting will definitely help us to overcome these challenges. So before taking the, just to give a brief view, before taking the transfusion details, we have to take the consent of the patient. These are the consent forms which should be duly signed by the treating doctor or the resident on the duty, and it should be explained to the patient that what is going to happen during the transfusion. This is the requisition form, which is the manual one, in which you have to fill all the details of the patient regarding the hospital details, about the treating doctor, diagnosis, indication, number of units required, along with the person who is taking the sample. This is very important because nowadays we are rejecting the samples from the blood center. We are not accepting those samples and the forms. These are the specific requirements which have been mentioned on the forms, whether the blood is required as a stat or for the urgent, and accordingly. In the emergency situations, please mention if there is no identity of the patient, whether like unknown 1 and unknown 2 on the label, on the forms as well as on the samples. Do's are most important. Please label the sample at the time of the collection. Don't oversign for the work of another person. As we are we are now JCI accredited. So initially we were using 2 identifiers, but as per the international guidelines, we have to use 3 identifiers, that is name of the patient, IP number of the patient, and the UMR number of the patient. And remember, once the blood is issued from the blood center, it will not be returned back. So always get it issued when it is required. Check the blood group with the list of the patient, with the file of the patient. These are the stickers which are placed on the blood bag labels showing the cross-match report and the issue report. Just cross-check all the details. If any changes you found, please contact the blood center and return the bag immediately to us. The transfusion rate should be followed, because while doing the audits of the adverse transfusion reactions, we found that the blood was issued at 9:30 in the morning, but it was transfused at 1 in the afternoon, which resulted into the adverse reactions. do monitor the forms, whatever you are transfusing. This is a transfusion monitoring form which is available on the MGH policies folder. Please fill all the details and put the form into the file. And if any reaction occurs, fill this form, return the bag and the form along with the sample to the blood center. These are the traceability form which we have to complete as per the government guidelines, and we have to submit at the end of each month what unit was discarded, what was the reason of discarding the unit. And believe me, working in the blood center, it's very painful when we discard any unit without any reactive cause. And we are just mentioning the blood was not transfused to the patient, that's why we are discarding. So it's really very painful for us. And as I just at the end, I just want to say that MGH is blessed enough. It's a very big family. Together we can work very hard to overcome these challenges, and all these problems results into three things. One is the harm to the patient, the reputation of the institute, and thirdly, the cancellation of the blood bank licenses. So I request everyone to please follow the guidelines and help us not to face such challenges again. Thank you.